Chapter 31 is going to be moving into chest and abdominal trauma with the main goals here understanding chest injuries and abdominal injuries and then the emergency care for those injuries. As you can imagine, the chest and the abdomen are the core of your body, and it spells for bad outcomes with significant trauma to these areas. So we'll plug our way through the chapter, learn about these, and hopefully have a better understanding of how to care for these at the end of it. It's important to understand what the chest cavity is, what's in the chest cavity. So the chest cavity basically extends from the collarbone to the diaphragm. And it's kind of a dynamic area because the size of that chest cavity depends on the respiratory cycle. So as you breathe in, you take in more air, that diaphragm flattens out. That chest cavity grows a little bit. As you breathe out, that diaphragm pushes up and that chest cavity shrinks a little bit. So it can really extend anywhere from the nipple line down to basically the belly button, depending on your respiratory cycle. You would think, there's not really a whole lot in the chest cavity, but what's in there takes up so much space that it's just packed with organs and really major blood vessels, and then the lungs. So the heart being the main organ that's in there with the lungs, but really it's all the vessels coming off of the heart that feed the rest of your body. There's just an enormous amount of blood product that would be in your chest cavity at any one given time. So any damage to that chest cavity can result in high mortality rates because you can lose a lot of blood in a very short period of time. Now with that, the chest cavity is also one of the most protected areas of the entire body. You have the ribs that protect all the way around the outside, and you have 12 sets of ribs. And then you have the sternum that connects your ribs together in the front that gives you the maximum protection over your heart muscle. And then in the back you have the thoracic spine vertebrae, which protect your spinal cord going down. And then in the upper portions of the back you have the scapulas or the shoulder blades, providing even more protection back there. So it does take significant trauma, unless it's a penetrating trauma, to do damage, but like I said, once the damage is done, it can be very, very bad for the patient. From a physiological standpoint, there's a lot going on in the chest. You have the heart, which is continuously beating, that's providing the blood flow, and then you have the large major vessels that come off the heart. They're going to feed the heart itself, and then they're going to split off, they're going to feed the brain, and then the descending aorta is going to go down and feed the rest of the body. They are very large vessels. If any one of those vessels rupture, it's almost a certainty that it's going to be a mortal outcome for the patient, and they will probably end up deceased. There's just not a lot you're going to be able to do in that situation. Next, we'll talk a little bit about the respiratory function and what the lungs do within the chest as well. So the mechanism of breathing and kind of how it works is it's all tied to the chest wall, diaphragm, and lungs working together. And by doing that, they change the pressure within the chest cavity, and that causes the air to move in and out. So the lung tissues that occupy the space adhere to the chest wall, and then they use a lubricating liquid with constant negative pressure. That adherence to the chest wall allows those lungs to expand and contract with movement of the chest wall and then contraction of the diaphragm. The expansion and contraction of the lungs change the pressure that leads to the movement of air. So if there's any failure with any of this, it can create issues with the breathing, respiration of the patient. If you have any sort of penetrating trauma, it can change that negative pressure within the chest wall, which can create other issues for the patient as well. With the inhalation process, it's the active process that uses negative pressure to draw in air. So the diaphragm contracts and flattens while at the same time the intercostal muscles, which are the muscles between the ribs, they'll expand and flex, which expands the chest wall outward. Those two actions together will increase that chest cavity in size, and when they do that, it draws air into the lungs. Now, when you exhale, the opposite happens. So the intercostal muscles relax, the diaphragm expands upward, and that pushes the air out of the chest cavity, out of your lungs, and that's what the exhalation process is. It's a passive process that uses positive pressure to push air out of the lungs. Now, as we move down to the abdomen, we know the diaphragm is the lower portion border of the chest cavity. So in the same sense, the diaphragm is the superior upper border of the diaphragm. The abdominal organs extend to the lower regions of the pelvis, and then we actually will break the abdomen into 4 quadrants that you'll have a little bit better understanding. It's basically taking a crosshair and putting it over the belly button, and then you break it into upper left, upper right, lower left, lower right quadrants, and then the next image will show you kind of a visual of exactly what organs are located within the abdomen. So this image is going to kind of show you the breakdown of the solid organs versus the hollow organs. The thing to remember is, like we talked about in the last chapter, the solid organs are going to have the tendency to bleed a lot if they're damaged. The hollow organs are going to have the tendency to leak out their fluids, which could cause other issues and long-term issues, including infection and sepsis if they're damaged. So if your patient has trauma to the abdomen, and as you do your assessment, it's important to understand which organs fall into which quadrants, so that you can kind of predict injury patterns based on what those organs are. So if a patient was shot or stabbed in the upper right quadrant, you'd have to be worried about liver, gallbladder, those organs. You also need to be able to understand that you can differentiate between hollow and solid organs. We've already talked about kind of the concerns with both of those, but from a general standpoint, hollow organs are going to tolerate the trauma fairly well because there's some give to them. Obviously, if it's a penetrating trauma, they're not going to tolerate it very well, but any blunt trauma, they will kind of bounce and cushion themselves a little bit, so they'll tolerate it a little bit better. Solid organs, not so much. Take, for example, dropping a balloon on the ground. It's hollow. It's going to bounce. You fill that balloon with water. You drop it on the ground. It's going to pop and kind of explode all over the place. Kind of the same concept here with the solid organs. If they hit that trauma, they have the tendencies to fracture, lacerate, and then you have more significant bleeding from them. A couple more things to consider when you're talking about the abdomen, and that's the physiology of the abdominal organs is dependent on the individual function, meaning depending on what organ is damaged is going to contribute to what effect it has on the body. They all have different jobs that they do for the body. So if you damage the liver versus damaging the intestines, it's going to have different effect on the body, just depending on the situation. Also, same as the chest cavity, the abdominal cavity is very dynamic depending on that location of the diaphragm. So as you breathe in and out, the organs of the abdomen are going to shift around a little bit too. So it's a dynamic and ever-changing area based on your breathing patterns. Similar to the chest as well, there's a large amount of blood in the abdomen between the descending aorta and the returning major vessels, as well as all the arteries that feed your organs and feed down into your hips and pelvis. There's a large blood volume in there. Again, if you were to rupture any of those major vessels, blood loss is going to be very rapid. It can be a very poor outcome for the patient, so your assessment is very key. The assessment of the abdomen is a little bit more difficult just because of all the organs that are in there, and it's soft. So you have to really practice the assessment of that and understand the nature of what's going on in there. Now, when we're thinking about chest and abdominal trauma, we can kind of divide these into three categories. And then a fourth category, that's more of a delayed response, but it's still significant enough to understand. Those three categories are going to be disruption of breathing, and that's going to be when a trauma occurs to the chest, and immediate concern is breathing. So if you have any sort of penetrating trauma that's going to allow outside air into the chest, or trauma that's going to allow blood to fill into the chest, those two things can take up the chest cavity and basically collapse the lungs down. And when that happens, it can be a fatal outcome for your patient. So chest trauma is a significant concern. Even with minor injuries like rib fractures or blunt contusions, they'll cause severe pain, and more importantly, with the inflammation in the tissues, it can impair the breathing as well. One of the biggest concerns is going to be of hemorrhage and shock, and that's going to be of any damage to those large vessels anywhere in the chest or abdominal cavity can cause a rapid blood loss. And when you have that rapid blood loss, you're going to have to revert back to our chapter on shock to understand that this can be also a very fatal outcome for the patient. So your assessment skills, your monitoring of vital signs so that you can kind of stay ahead of the shock trends is going to be very key through your assessment and transportation process. The third thing being a disruption of organ function. So with all of those major organs within the chest and abdomen, if you have significant damage to any of those, it can cause long-term effects and can also be fatal for the patient. It just kind of depends on what the organ is. Obviously, if you have significant trauma to your heart, it's going to have a higher fatality rate than if you have, say, major trauma to your intestines. But disruption of organ function is another key takeaway from trauma of the chest and abdomen. Finally, the last thing here, and it's going to be delayed, but it's the threat of infection with chest and abdominal trauma. So anytime that you have injury, especially if you have an open injury to the abdomen or chest, it opens up the fear of infection, which can eventually lead to sepsis. So this isn't something that you're necessarily going to see up front immediately with the trauma. It's going to be in the hospital, but potentially if a patient is discharged after they've had a traumatic injury, it could be something that the infection sets in, and then you end up transporting a patient to the hospital kind of after the fact, and that can also be very detrimental for the patient. Okay, now we're moving into chest injuries, and the first thing we'll talk about here is the different mechanisms of injury. So the first one being blunt trauma, and that's going to be trauma in which there's no penetration into the actual chest cavity from the outside. But still, blunt trauma can cause significant damage internally because you can fracture the ribs, the sternum, the cartilage between the ribs, and then if those fractures are bad enough, they can actually damage the internal organs that they protect. So even though you may not see the damage on the outside, there can be significant damage on the inside. The next one here is going to be penetrating trauma, exactly as it sounds. So bullets, knives, anything that really penetrates through the skin into the chest cavity. It can cause damage to the outlying structures, so it can fracture bones. But more importantly, it can damage those internal organs. It can impair respiration. It just depends on the pathway of what that penetrating trauma is. So you'll have to use your assessment skills and understand exactly what it was that penetrated into the body so that you can make better judgments as to what potential injuries there could be. Next category here is going to be of compression and shearing injuries. Compression injuries are going to occur as a result of a blunt trauma but it's going to be something that causes that chest to rapidly compress. So imagine a car without an airbag, and you're not wearing your seatbelt. When you shoot forward and your chest strikes that steering wheel, it's going to compress it very rapidly, and that's going to cause compression injuries within the chest. Shearing injuries are more of high energy injuries that can damage the aorta or vena cava. Shearing injuries are seen due to a sudden deceleration and also because of seatbelt related injuries. Um, Honestly, there's one injury that is a kind of a low impact. If you get to this scene, you're going to see the vehicle and think, "Wow, why was this a fatal accident?" But if a vehicle is broadsided or sideswipes into a tree, whatever the case may be, at a fairly low rate of speed, it can actually shear and dissect the aorta coming out of the heart, just because of the way that it's set up. Always be aware, even on what seems to be a minor impact, if it's a side impact, that it is a concern with these shearing injuries. As far as classifying, we either classify these chest injuries as open or closed. So an open injury is obviously going to be something that's open from the outside. A closed injury is going to be something that's closed on the outside. So some of these blunt chest injuries that we'll talk about. First one being rib fractures. And it's most commonly identified by considering the mechanism of injury. And really just about anything can cause these, from falls to sports injuries to motor vehicle crashes that cause the blunt trauma. Really just about anything can cause rib fractures. They're extremely painful. They take an extremely long time to heal because your ribs are constantly moving with the breathing process. So they're very difficult to heal as well. It can make breathing difficult. Generally speaking, they're not life-threatening. However, there can be situations where you need to take into consideration that it may be more severe. It can lacerate blood vessels. It can damage lung tissue. If the rib breaks all the way through, it could potentially penetrate into the lung, causing the lung to collapse. So there's really a wide variety, but for generally speaking, they're not life-threatening, but your patient will have a lot of pain with these. A flail chest is going to be when you have rib fractures, but they fracture in two or more consecutive ribs in two or more places. So you kind of have this free-floating chunk of ribs that's not connected to the rest of your rib cage. It's going to leave that portion of the chest wall very unstable, and it's going to lead to inadequate breathing and hypoventilation. What you might see with the flail chest is called paradoxal motion, and that's where the movement of that flail section is opposite to the movement of the remainder of the chest wall. The next couple slides are going to give you kind of a visual of what this flail chest looks like and kind of what it would look like with the breathing process. But basically, when your chest wall expands, this segment of ribs that's broke free will actually move inward. And when your chest wall comes back in, it will move back outward. This can be a very serious issue for the patient, but it can also be difficult to assess. The more ribs that are involved, the easier it's going to be to see, but it can be difficult to assess. As for the assessment process of the rib fracture, first thing and foremost is consider the mechanism of injury to understand the potential for a rib fracture. Understand where their pain site is and what could be involved. They may have pain at the site of injury, and that pain it may or may not increase with breathing, but it is likely that it will increase with breathing. They'll also have tenderness. You may see some bruising of the skin around it. You want to make sure to feel for any deformities, and then you want to observe and monitor for any signs of respiratory distress, hypoxia, or respiratory failure that would obviously indicate that there's a bigger issue going on and that the damage maybe caused more of an injury than what outwardly you see. One thing that you can do for the patient is called self-splinting. So you can allow them to hold a pillow or something else against their chest to kind of hold that area into place a little bit. The one thing you don't want to do is restrict the chest wall movement in any way. So don't strap it, tape it, don't band it with an ACE wrap or anything like that, because it can restrict the patient's breathing and then potentially cause bigger issues down the road. Now with the flailed chest, again, understand the mechanism of injury and the capability that it caused a potential flailed chest. Really, you want to be watching for any difficulty breathing with the patient. You want to assess and see what the pain is at the injury site. With the flailed chest, it's a little bit bigger concern, so think about administering high concentration O2. Consider ALS early for pain management. You're watching for signs and symptoms of shock and hypoxia. Some systems may let you use a CPAP, but I would get medical approval prior to doing it in this situation. Monitor that patient very carefully, watching their respiratory rate and depth. If it becomes that the patient is hypoxic or that they're not ventilating appropriately, be prepared to have that BVM out to assist them in those situations. And again, kind of adding to some of what we talked about with the patient assessment. With the rib fractures, also consider the need for ALS for pain management. It's also good for ALS because if it does become a respiratory issue, they're going to be able to put an advanced airway in that patient to assist their breathing more effectively than what you may be able to do with just a bag valve mask. Allow them to remain in that position of comfort unless you have spinal precautions that are needed. And we'll talk about that in an upcoming chapter. But some traumas, you're going to have to put them on a backboard and secure them to a backboard. It used to be that all traumas got secured to the backboard, but that's changed significantly over the years. So if you don't have to put them on the backboard, let them remain in whatever's comfortable for them. Be prepared for hypoxia and treat that hypoxia. And then, like we talked about, the self-splinting using a pillow, but make sure not to band it. And then again with the flail chest, use your primary assessment. Be prepared for any life threats. They are a little bit more likely with the flail chest than just rib fractures. Administer O2 to these patients. And like I said, be prepared for inadequate breathing and the necessity of assisting them with that ventilation. Use your protocols, use your medical control, call them whenever you have questions. Utilize ALS in these situations. Monitor these patients very closely, pretty much continuously watching their respiratory drive, the rate and the depth. And make sure that you're not doing anything that restricts the chest wall movement. Years ago, we would actually put sandbags on a flail chest because they felt like that would hold the pieces together. But it's actually contraindicated now. You want to allow that chest wall to move freely. Moving on to penetrating chest injuries. So first thing that you need to keep in consideration is that it's going to be difficult to tell what's injured from an entrance wound. And the entrance wound itself can be difficult to assess. Like a 9mm gun is going to leave, in theory, a 9mm hole. That's not very big, but it's high velocity and can do a very significant amount of damage within the chest. So anytime that you find an entrance wound, assume that all wounds are going to be life-threatening. With the chest cavity especially, those open wounds are going to allow air into the chest. Like we talked about earlier at the beginning of the chapter, that is going to cause an imbalance in the pressure. And that imbalance in the pressure can actually cause your lungs to collapse. If one lung collapses, the other lung will try to take over the full workload, but your patient is going to be critically ill at that point. If both lungs collapse and nothing's done very immediately following, it will be a fatal outcome for your patient. It's important in the assessment process to determine what the object was that penetrated, so that you can uh, try to estimate the depth in the potential for injury to the underlying organs. If you find one penetrating wound, make sure you look for others. You're going to assess the front, the back, the sides, every place. It could be that one is an entrance, one is an exit. At that point, it's not going to matter. You're going to treat them both as penetrating injuries. It's also very important to relay any entrance wounds slash exit wounds when you give your radio report so that the ER can be fully prepared for what you're bringing into them. You want to make sure that you're listening to lung sounds on these patients. The goal is to have clear lung sounds in all fields, but hopefully your assessment skills will help you identify the potential for pneumothorax or hemothorax, which is going to be air or blood that's causing the lung to collapse. Some of the key things that you can look for with lung damage as far as signs and symptoms are going to be obviously any difficulty breathing, respiratory troubles, absent or unequal lung sounds is another good indicator. Make sure that you're listening to all fields, not just the uppers, which is not that uncommon in the ambulance for paramedics and EMTs to get lazy and just listen to one field. You want to make sure that you're listening to all areas of the lungs. Hemolysis is the coughing up of blood. That can also indicate some internal damage when they're coughing up blood. And then hypoxia will also indicate damage to the lung system as well. And then you need to be prepared to treat these as well. Other signs that you're going to see are going to obviously be shock with the blood loss, increased heart rate, increased breathing rate, look for pale skin, and then look for low blood pressure as well. Remember that the body's going to compensate initially before it starts to decompensate. So you're using your assessment skills to look for all of these signs and symptoms. Now, if the patient does have a penetrating chest injury, one of the more critical things that you're going to be looking for is called a sucking chest wound, and that's that negative pressure through the respiration process. It's instead of drawing air in through the natural methods, it's going to allow that air to be drawn in through the hole in the chest. You'll kind of hear that whooshing, sucking sound, and then you may see small air bubbles within the wound, indicating that it's affecting the respiratory process. If it gets more severe, it may get to the point where the patient's actually gasping for air because their lungs aren't able to get the oxygenation the way that they should, and this air is being sucked in, putting all of this pressure on the lungs. When looking at the patient care for these, again, first and foremost is your own safety. So make sure that law enforcement has rendered the scene safe. Don't go running in because if there's a perpetrator there, you don't want to become a patient yourself. Consider the need for ALS and consider it early. If your dispatchers give you the information early on that there's some sort of penetrating chest injury or significant chest injury, then I would contact ALS even prior to getting to the scene. Like we've talked about in other chapters, you can always cancel ALS, but you would rather get them there quicker if at all possible. Then we move into that primary survey. So ABCs, make sure that the airway is open. And then you want to also make sure to seal the wound. Now, how you seal this is going to be a little bit situational. One of the ways is with an occlusive dressing, which we'll talk about in a couple slides. Just because they have penetrating chest injury or potentially even a neck injury doesn't necessarily mean that you need to use spinal precautions. And in actuality, if at all possible, you want to leave these patients in a position of comfort because laying them down supine can actually be detrimental and knock out their respiratory drive, leading to more issues. You're going to want to administer high concentration O2, so 15 liters by non-rebreather. Use your assessment, monitor vital signs so that you can treat for shock And like we've talked about so many times, short scene time, rapid transport, and then back to calling for ALS. Now, dressing these open chest wounds, the go-to is going to be the occlusive dressing, and that's going to seal the wound and stop any movement of air. Now, with that, you may need to use what's called a flutter valve dressing, and that involves taping the dressing in place, but you're going to leave a side or corner of it unsealed. So that way, when the patient inhales, the dressing will kind of suck down on all sides and seal the wound and not let any outside air. When the patient exhales, it's going to kind of push that dressing up, and if there's any free air in the chest, it's going to allow that air to release from that being trapped in that chest cavity. Commonly what we use is called Vaseline gauze, and basically it's just gauze with Vaseline on it, so that way when you tape it down on three sides and you breathe in, it pulls down the Vaseline, allows it to kind of adhere around, but it also still lets it release when you exhale to allow that air to release. Now, this next batch of slides is going to talk about some specific injuries within the chest cavity. So what we're going to talk about here is going to be the pneumothorax and the tension pneumothorax, uh, the hemothorax and the hemopneumothorax, which is going to be similar to the first ones, but blood is going to be the issue. Traumatic asphyxia, cardiac tamponade, and then aortic injury will be the last one we talk about. The first two here is going to be the pneumothorax and the tension pneumothorax. So the pneumothorax is when air accumulates in the chest cavity through one of those potentially penetrating wounds. It can also be spontaneous pneumothorax, which can occur just naturally in people with frail lungs. But it's any air that gets into the chest cavity, whether it's internal or external, that causes that lung to collapse. So the air is going to build up. It's going to push the lung tissue away from the chest wall, and the more air that accumulates, the more it collapses the lung. Now, just in general, a small pneumothorax, there's not going to be a whole lot you have to do from a treatment standpoint, and the patient may not exhibit any real severe signs or symptoms. But as it progresses, it's going to progressively get worse for the patient. If it progresses to the point that air actually compresses the lung all the way down, it can start putting pressure on the heart and the vena cava. This is called a tension pneumothorax, and it becomes especially critical for the patient because of a number of factors, from kinking off the vena cava to compressing the heart and preventing it from filling. Patients with a pneumothorax, they're typically going to have diminished or absent lung sounds on the affected side. So if you hear good lung sounds on one side and they're gone on the other side, that's going to be a key indicator to some sort of pneumothorax. Another sign that you will look for is that the trachea may shift to the opposite side. So basically your trachea is going to want to line up with the good lung. So if your right side is got the pneumothorax, your trachea will shift to the left to try to draw a straight line to the good lung. That's also a very key indicator. You need to be prepared for shock as these get worse. The other sign that you'll look for is that those jugular veins may be distended as well. So you're looking for those diminished or absent lung sounds on the affected side, the JVD, and then the trachea that may shift to the opposite side. Now some of these are going to occur a little bit later on when it progresses into a worsened state. So you may not see them initially. The first one that you will probably notice on your assessment is going to be the diminished or absent lung sounds. The next couple here are the hemothorax and the hemopneumothorax. So the hemothorax is going to be similar to the pneumothorax, with the exception of instead of air compressing the inside of the lung, the chest cavity, compressing the lungs down, it's going to actually be when that cavity fills with blood compressing everything down. So this can be from an open or a closed wound, depending on what causes the bleeding inside. And then finally here, the hemopneumothorax is just put the two together. Hemo is going to be blood, a pneumo is going to be air. This is kind of a combination of both things, where the chest cavity is actually going to fill with blood and air, compressing on the inside of the chest cavity, compressing the lungs down. Traumatic asphyxia is going to be when there's a sudden compression of the chest, forcing that blood out of the organs and rupturing the blood vessels. So it's a very significant compression of the chest area. It's usually going to be lethal for the patient. The neck and the face will usually be darker because they're more or less have bruised, because the arteries and vessels will have ruptured, causing that bruising. The pressure may also cause things like bulging eyes, distended neck veins. Like we talked about, it's going to break the vessels in the face. So it is a very significant amount of pressure that does this. And like I said, it is almost always lethal for the patient. Now, cardiac tamponade is going to be when there's an injury to the heart, and then the sac that surrounds your heart and encapsulates your heart, that sac becomes filled with fluid. So there's actually a buildup of blood between the sac and the actual heart muscle. That pericardium, it's a tough sac. It usually very rarely leaks. So as the blood starts filling in that sac and creates more and more pressure, it's going to continue to squeeze that heart until the heart really can't take it anymore, causing the patient to go into cardiac arrest. This patient needs to be in the ER rapidly, because if it's assessed and treated properly, there are ways to drain that sac, but it's nothing that you can do from a pre-hospital standpoint. So good assessment, rapid transport, get them to the hospital is going to be key for these. That increased pressure, it's not going to allow the heart chambers to fill. So just depending on how rapidly that sac is filling with blood, is going to kind of determine the outcome of the patient. Now, what you'll see with these is as the blood backs up into the veins, it's usually going to be a result of penetrating trauma. You're going to see distended neck veins. You're going to see signs fairly rapidly of shock, and the patient is going to have narrowed pulse pressures. And then lastly here is going to be the aortic injury. So the aorta, being the largest artery in the body, comes off the heart and then becomes the descending aorta, which travels down the chest cavity into the abdominal cavity. Penetrating trauma can cause direct damage to this, and you will have massive blood loss in short order depending on that penetrating trauma. Blunt trauma, as we talked about with a couple slides earlier, it can actually sever or tear the aorta. If that occurs, it's almost a certainty that they will lose blood so fast that the outcome is going to be very poor, resulting in death. Now, two things that can occur here are aortic dissection, and that is when the inner layers of the aorta begin to tear. So like I said, you will lose blood very rapidly with this. The blood's going to actually flow between the layers of the aorta's wall. Like I talked about, it's almost always going to be rapidly fatal, just because the blood loss is going to be so severe internally from this. Now, an aneurysm is actually going to be a weakening of that aortic wall, and a balloon-like protrusion of the aorta is going to occur. So imagine filling a water balloon Um, if that water balloon flat is your aorta, and as you start filling it and it swells up, that's creating an aneurysm. Now, at a certain point, the pressure on that aneurysm can rupture. If it ruptures, similar to the dissection, you're going to lose blood at such a rapid pace that there's really nothing you're going to be able to do for the patient. It's going to lead to patient death. Now, if your patient has an aortic injury, they're going to generally complain of pain to the chest, abdomen, and or back. They will usually show signs of shock, so make sure to acquire your vital signs. If you're concerned that there could be an aortic injury, you may see a difference in pulse or the blood pressure between the right and left arms, or the legs themselves. Another thing is, as you're palpate gently. If it is an aneurysm, you may actually feel what feels like a mass, but it may be pulsating. If it's on the descending aorta, where you can palpate and feel that. Like we've talked about, this is going to be difficult to assess, but you want to treat your patient's complaints. Most importantly, be prepared for that shock. Comatio cordis is going to be translated to a commotion or disturbance of the heart. It's fairly uncommon, but the possibility is there. Every time your heart beats, there's a few hundredths of a second where the heart is electrically vulnerable. And so if there is a trauma to the center of the chest during this vulnerable period, it can actually trigger your heart into going into ventricular fibrillation. Treat it like you would any cardiac arrest patient in VFib. If you can start CPR immediately and get defibrillation rapidly, it is usually fairly easily corrected. Commonly, it'll occur in sporting events, things like baseball hit back at a pitcher, and the ball hits the pitcher right in the center of the chest. Just that very split second of time that heart is vulnerable, something like that can trigger this to happen. So if it does, just be prepared with your BLS to treat your patient like any VFib patient. So with patient assessment, things we want to look for: pneumothorax, we're looking for those breathing problems. You're looking for uneven chest wall movement, a reduction or absence of breath sounds on the affected side. Those are going to be the key indicators. If that progresses into a tension pneumothorax, you're going to see increased respiratory difficulty and signs of hypoxia. Your patient is going to become shocky, so make sure that you're assessing vital signs, skin signs, everything that would indicate shock. You're going to start seeing those neck veins distend out, and then you'll start seeing that tracheal deviation where your trachea is trying to line up with the good lung. As far as a hemothorax go, it's going to be very similar to a pneumothorax, but they may be coughing up a frothy red blood. On to traumatic asphyxia, again, distended neck veins. You're going to see that darkening of the head, neck, and shoulders because the vessels will rupture at the surface, giving them a bruised look across those areas. You'll see the bloodshot and bulging eyes from the increased pressure that happens very rapidly. Their tongue and lips may become swollen or blue, and then they're going to have chest deformity and or tenderness if they're conscious. The cardiac tamponade, again, you're going to see distended neck veins. So don't just get tied up when you see distended neck veins, because that can mean really a number of different things. But now with the cardiac tamponade, the pulse is going to be weak. It's going to be harder to feel. Their blood pressure is generally going to be lower, and then you're going to steadily see a decrease in those pulse pressures. With the aortic injury or dissection, if the patient states that they felt a tearing pain that radiates to their back, that's going to be a very good indicator. You're going to see those differences in pulse or blood pressure from the right to the left side. Again, gently palpating, you may feel a pulsating mass. And when I say gently palpating, Keep in mind that that is a weakened structure. So just by palpating, you could potentially rupture it. So be very gentle when you're palpating. And then eventually this will progress to cardiac arrest, and then you will treat your patient just for typical cardiac arrest. Now, to care for a pneumo or tension pneumothorax, first call ALS. If you can call them before you get to the scene, that's going to be best case scenario. Seal any of those open chest wounds using the occlusive dressing with the flutter valve. Allow air to be expelled utilizing that flutter valve. Basically, back to your ABCs. Monitor the patient's airway. If their airway becomes an issue, be prepared to use the bag valve mask or insert airway adjuncts. Administer oxygen to treat hypoxia, so make sure that you're getting a pulse ox on this patient. And then allow that patient to remain in a position of comfort so that the air can move freely, like we talked about. Sometimes laying them down flat is enough to knock out the respiratory drive, and then you better be prepared for respiratory arrest. Now, beyond those injuries, really any other injury, airway. Be prepared to maintain that airway. Be prepared with your bag valve mask. Be prepared with your airway adjuncts. Be prepared to apply suction to these patients. Utilize supplemental O2, 15 liters by non-rebreather. Follow your local protocols for any type of dressings. And when in doubt, utilize medical control. Call them, ask them questions. They will give you direction. That's what they're there for. Be prepared for shock. Monitor vital signs frequently. Short scene time, rapid transport, and then anytime that the chest is involved, to consider the need for ALS because you're always concerned about respiration and breathing with these patients. Talking about abdominal injuries, these injuries again can either be classified as open or closed. So has the outside been opened up to the inside, or is it just an internal injury where there's nothing open on the outside? Your big concerns are going to be internal bleeding. It can be very severe if the organs or blood vessels are damaged or ruptured below the surface. Remember, back at the beginning, you have a large number of organs and really a large number of vessels throughout your entire abdomen. Understand what those organs are, what they do, and then what quadrants they're located in. So that way, if there is damage to the abdomen, you have a better idea and can kind of predict some of the injury patterns. Another thing to be concerned about with open wounds is called an evisceration, and that's where those organs will actually protrude through the wound opening. So it's not uncommon to see somebody with a significant open abdominal injury maybe having some intestines poking out, and the next image will show you exactly what that is. A couple things that we have touched on here. So with the blunt trauma, remember that the solid organs can cause life-threatening blood loss. Remember that they do not tolerate the blunt trauma nearly as well as the hollow organs. So be prepared for blood loss. Make sure that you're assessing and understanding where those organs are located at so that you can better predict the injuries. Injuries to the diaphragm can actually cause a detachment, which is going to basically create a hole between the abdominal cavity and the thoracic cavity. If this occurs, it's entirely possible that some of the abdominal contents may spill up into thoracic cavity. This is going to create a couple different issues, one being breathing. Be prepared for respiratory distress with your patients. Your diaphragm does a lot of work with your breathing, so if it's damaged, it can impede the breathing process. But also, as these contents enter into the thoracic cavity, remember that there's only so much space in that thoracic cavity. So if something else has entered taking up space, it very well can start putting pressure on the lungs and the heart as well. If the hollow organs are injured, you have to be aware of what those contents are and that they can spill into the cavity of the abdomen, causing severe irritation and peritonitis. Again, not something that necessarily will kill them immediately, but it is a life threat because of the contents that are in there and the infection that risk that it poses. So with the patient assessment, things that we need to be looking for is pain. It may initially be mild, but it can progress and become very intolerable for the patient. You may see cramps with the patient. You may see nausea with the patient. You may see weakness with the patient and thirst with the patient. There may be obvious lacerations and puncture wounds to the abdomen. Again, you want to just treat these as we've talked about previously. You also want to make sure, as far as the pain goes, that you're getting an initial assessment on the pain and you're having them rate their pain on a scale of 0 to 10, with 10 being their worst, so that you can trend their pain throughout the transport process to understand exactly how much worse it's getting. You may see lacerations and puncture wounds to the pelvis, the mid, and the lower back. Like we talked about with the chest, make sure you're doing a full assessment. Make sure you're identifying where all of these punctures or lacerations are so that you can relay them to the hospital so that they can better prepare for your arrival. Look for indications of blunt trauma. Look for the bruising of the abdomen. That's going to be one big key indicator. And then be prepared for developing shock. If there's damage on the inside where there's blood being lost, you will eventually start seeing those signs and symptoms of shock that you will need to treat. Also be prepared and understand that coughing up blood and vomiting blood is also two things that you may see. You may see a rigid, which is a firm, or a tender abdomen when you palpate. Generally speaking, when you're palpating the abdomen, you want to start in the opposite corner from where the pain is and then work your way to the area of pain. The abdomen may also be distended or basically swollen out. The patient's going to want to try to lie very still. They may want to try to be in the fetal position as well. Now, if it's a gunshot wound, and that gunshot wound happens to be at the lower ribs, and there is an exit wound at the same level, then you want to make sure that you're treating this patient for both chest injury and abdominal injury, just because of that ever-changing area of the chest and abdominal cavity that we talked about, depending on your breathing patterns. But the other thing that you need to consider is that bullets often don't take a straight path through the body. They will hit things, they will bounce off of things, they will deflect. So just because you see an entrance hole and you see an exit hole, you don't necessarily want to draw a straight line between the two, because that's not how it works when the bullet actually impacts inside the body. Now, for both open and closed abdominal injuries, there are some things as far as patient care goes that pretty much is going to be the same throughout. First, be alert for vomiting, and then make sure that you keep the patient's airway patent if they are vomiting. Place the patient on their back with their legs flexed up to their knees. That's going to reduce the amount of pressure on the abdomen and the abdominal muscles, and it's probably going to be the position of most comfort for the patient. Administer supplemental O2. Be prepared for shock, as with everything we've talked about in this chapter. For these patients, make sure you give them nothing by mouth. These are more than likely going to be surgical candidates, so you want to make sure to give them nothing by mouth. It's also going to be something that if you did give them water or something else, that it can actually make their condition worse. Continuously monitor their vital signs. Keep a close eye on their blood pressure, their pulse ox, their respiratory rate. Look for any signs and symptoms of respiratory distress. Short seed time, rapid transport. Consider that need for ALS. Some additional information on abdominal injuries here. Control the external bleeding and dress all wounds as you would with any external bleeding. As far as eviscerated organs go, do not touch them, do not poke them, do not prod at them. Apply a sterile dressing that you've moistened with some sort of sterile saline over the wound. You want to make sure that you moisten it, otherwise that sterile dressing will stick to the eviscerated components, and then it could create a bigger issue for the patient. If it's a large evisceration, maintain warmth by placing layers of bulky dressing over that occlusive dressing as well. And then finally, with the open abdominal injuries, don't remove any of the impaled objects. Stabilize them with the bulky dressings bandaged in place, like we talked about with impaled objects in the previous chapter. Leave the patient's legs in a position found to avoid any muscular movement that may move that impaled object around. Try to keep it as still as possible unless you absolutely can't transport with them. In that situation, get medical control involved so that you have direction on what you need to do. So this is going to conclude the chapter for chest and abdominal injuries. Go ahead and look through the chapter review. This will conclude this lesson as well, so we'll get the unit quiz up for you guys to take. If you have any questions, make sure to let us know.